This is Dr. Kriti Mehra from St. Vincent Hospital, and I'd like to thank you for considering my abstract for a poster presentation. I'm here to talk about my abstract titled The Curious Case of Pancreatitis. And no, that is not a typo that you see. Acute pancreatitis is an inflammatory condition of the pancreas characterized by abdominal pain and elevation of pancreatic enzymes. It is most commonly caused due to gallstones, alcohol use, and hypertriglyceridemia. Local complications can include pseudocyst formation and pancreatic necrosis, whereas systemic complications could be ARDS, renal failure, or shock due to a systemic inflammatory response syndrome. Here I'll be discussing a less common complication of pancreatitis, or should I say pancreatitis? A 38-year-old female with a past medical history of hypothyroidism and alcohol use disorder presented to us with chief complaints of abdominal pain for one day. It was sharp in nature, located diffusely in the abdomen, and radiated to her back. It was associated with nausea, vomiting, and a sharp pleuritic chest pain. However, no aggravating or relieving factors were noted. Her vitals were significant for tachycardia, and she had marked epigastric tenderness on her physical examination. Her labs revealed a leukocytosis of 12,800, AST 172, ALT 49, and an ALP 154. Her lipase was high at 2035. CT of the abdomen pelvis showed findings suggestive of acute pancreatitis. Even though her Wells score suggested low probability for a PE, a CT-PE was obtained due to her tachycardia and pleuritic chest pain, and lo and behold, it revealed a small saddle embolus and an embolus in subsegmental arteries in the upper and lower lobes. Right heart strain was ruled out by an echocardiogram, and venous duplex did not reveal any deep vein thrombosis. The patient was anticoagulated with a heparin drip and transferred to the ICU for management of shock. Her hospital course was complicated by necrotizing pancreatitis and abdominal compartment syndrome requiring surgical decompression, and she was then transferred to a tertiary care center for necrosectomy. Activation of the coagulation cascade by release of cytokines leads to a prothrombogenic state in pancreatitis. Thrombosis is most commonly noted in splenic, superior mesenteric, and portal veins due to their proximity to pancreas. Pulmonary embolism, or PE, is a rare complication of pancreatitis. Shortness of breath in such patients might be due to a number of reasons, which could be due to abdominal pain or due to a dreaded complication such as ARDS. PE should remain high on our differential, and a clinical suspicion for the same should prompt us to investigate with a CT-PE. As noted in our patient, Wells score might lead to underdiagnosis as it does not account for inflammatory conditions, hence should be used with caution. Mortality in patients with multi-organ involvement can be as high as 50%. Hence, it is important to investigate and treat these patients early in their disease course. Thank you.